Hi, I'm John Arvesen. I'm a sports medicine orthopedic surgeon here at Scottish Rite. I'm here with Avery, who's our patient today, to kind of talk through the knee physical exam. We're going to go through 5 steps through a thorough and systematic approach to evaluating the knee. This is the same steps for every joint in the body. We use inspection, palpation, range of motion, stability exams, and then special testing. Before we get started, I think it's really important, as we all have learned in school, that the physical exam is important, but the history is also just as important to kind of guide the physical exam. During the clinic appointment, I'm going to ask specific questions throughout the appointment to help me tailor in my physical exam to really understand the diagnosis. Questions that are really helpful are mechanism of injury, when did it happen, what type of sports are they playing, was it a non-contact or contact injury, and these can really help clarify what physical exam maneuvers you need to do. During the inspection portion of the procedure, I think it's really important to watch your patient as they walk in through the door. And sometimes I'll have them walk back and forth to see if they have any pain or an antalgic gait. I'll see if they have any foot drop or a steppage gait. I'll also look at their alignment to see if they're more knock-kneed or bow-legged. And I think that really gives you a good insight into what's coming through the door. Sometimes patients won't even be walking because they're in so much pain, and that can really key in your physical exam for later diagnostic steps. In addition to seeing the patient walk through the door, I will have her sitting at the table, and immediately I can see if she has any swelling, any areas of an effusion in certain parts of her knee that may have scars or prior incisions, any redness, any signs of infection. And that's really what I'm looking for when I see her sitting on the table. And then part 2 is the palpation. When we're doing a physical exam of the knee, it's really important to use your anatomy to guide your physical exam. And so instead of me just coming up here and kind of feeling on her knee, I'm intentionally pushing on certain anatomic structures to help guide my physical exam. So typically I'll either start on the inside or outside of the knee. And for her, I'm going to start on the lateral aspect of the knee. And I'm thinking through, based on the history that I've given, what anatomic structures are going to be hurting. And then I start pushing on those to make sure that I'm getting into the right diagnosis. So for palpation of the knee, it's really important to use anatomy as your guide. Specifically, if I'm thinking about this, I'll think about the history to guide where I start touching the knee. So if we're starting on the outside or lateral aspect of the knee, things that I'm going to be feeling are the fibular head, where the LCL attaches. I'm going to be feeling Gerdy's tubercle, where the IT band attaches. And then I'm going to be feeling the joint line, the lateral joint line, and then also the lateral femoral epicondyle, and also here's where a lot of patients will have IT band related pain. Once I've gone through that part of the knee, then I'll start working towards the front of the knee, where I'll be feeling along the patella. And a lot of patients that will have patellar tendonitis will have tenderness at the inferior pole of the patella or in the middle of the patellar tendon. Patients that have Osgood Schlatter's will have tenderness over the tibial tuberosity. And then once I've kind of gone through that part of the knee, then I'll start going more towards the medial side of the knee, where I'll start up here over the medial femoral epicondyle. Then I'll touch on the medial joint line. The MCL is right here, so I can press on the MCL. And then distally, I'll work more on the pes bursa. And these are kind of the major points in the knee that we're going to use our palpation part of the exam for. In patients that have anterior knee pain or have a history of patellar dislocations, it's really important to evaluate their exam with them sitting with their legs hanging off the table. And so during this part of the procedure, or during this part of the exam, I'll have the patient straighten her leg. And when I'm doing this, I'm watching the tracking of her patella. So have you come back down. So for her, you can see, come back up, you can see her patella tracks nicely and it's in a single plane. You can come back down. Some of our patients will have their patella track to the outside of their knee, or they'll have something called a jumping J sign. When patients have a jumping J sign, that indicates that they have anatomical features that predispose them to having patellar dislocations. And when I see that, that can change my surgical plan or my treatment plan for the patient. In addition to doing the palpation exam with the patient sitting up, I also like to do in my palpation portion of the exam to evaluate for swelling or an effusion in the knee. And we do a test called the Blotman test. And a lot of times, the way that we can evaluate for fluid in the knee is to lightly glide our hand over the medial aspect of the knee. And sometimes we can get a fluid wave from pressing on the joint capsule, and the fluid can move across the knee, and you can feel it on the other side. And so you can just slowly bring your hand along the medial aspect of the knee and see if there's any fluid shift. Another way that I like to check for fluid is by placing my fingers in the suprapatellar pouch, just proximal to the patella, and I can kind of feel for any effusion that way. One thing that I didn't note earlier is that it's critically important when you're doing your physical exam to use both legs to evaluate the patient. A lot of times people want to get really focused in on the hurt leg, and then they don't use the normal leg as a comparison. And so that's a benefit to us in the physical exam for extremities, is that we can use the normal leg to help guide what's abnormal. And I also will always start with the normal leg when I'm doing a physical exam. You really want to gain trust with your patient, and so by starting with the normal exam, your patient will know what you're going to do on the opposite leg, and so they're more relaxed and you're able to get a better exam. And so first thing I do is I have Avery here. I'm going to have her lay down with her leg all the way straight. And what I'm going to do is first I'm going to check her range of motion. And some of these patients will have hyperextension. Sometimes in patients with meniscus tears, if I perform this maneuver where I hyperextend their knee, sometimes they'll get pain on the joint line when I extend it. And so for her, she has about 5 to 10 degrees of hyperextension. She can reach full extension at neutral, and then I have her bend her knee up to see how much flexion she has. And so she has full flexion here, and it's symmetric to the normal leg. Once the range of motion test is done, I then start getting into the stability exam, which is our 4th step. Typically, there's about 5 main diagnoses when people come in with a traumatic knee injury. The things I think about are ACL tear, meniscus tear, patellar dislocation. We'll see a lot of patients with anterior knee pain or patellofemoral pain, and then a fracture. And so based on the history of this particular patient, I typically start with my Lockman exam, which is a great test to test the ACL. The way that you do a Lockman is as I'll slide the patient's leg and I'll kind of secure it with my hip right off the table. It gets her into a little bit of flexion and it stabilizes her leg. We want to make sure that she has trust in me that I'm not going to drop her leg, and that way we can get her relaxed to do the exam. Then I'm going to grab her distal femur with my left hand and secure it, and then with my right hand I'm going to grab her tibia and I'm going to anterior translate the tibia, and that gives me a firm endpoint for her Lockman exam, and that's the test that we do for the ACL. The next test that we do for the ACL is our pivot shift exam. So what I'll do is I'm going to pinch her leg with my elbow and it frees up my hands. And a lot of times patients that have an ACL injury, they're going to be guarding a lot. So sometimes this exam can be difficult to do in the clinic, but if you have them relax, I'm going to grab her leg, grab her tibia like this, and so we're going to put her into a little bit of valgus, internal rotation with an axial load. And the way this works is when a patient has a ACL deficient knee, is that the tibia is going to be translated anteriorly, and when I rotate her leg, the IT band is going to bring the tibia and reduce it back underneath the femur. So internal rotation, axial load, and then valgus, and that gives me my pivot shift exam. So after my ACL exam is complete, I then turn my attention to the collateral ligaments, so the medial collateral ligament and the lateral collateral ligament. And the best way to do the physical exam for that is I bring her leg off the table to about 30 degrees of flexion, and I stabilize that medial aspect of her knee, and then I'm grabbing her heel with my left hand, and then I give her a varus force, and there you can see there's a firm endpoint with that load, and then I switch my hands and do the valgus load and make sure that her MCL is working here. Once those are complete, I then evaluate the posterior cruciate ligament, and I'll sit on her foot with my thigh, and then I'll grab her tibia and do a posterior drawer. And that's where I'm pushing back on the tibia, and that puts the PCL under tension. Another way to look at the PCL is you get your thumb on the medial femoral epicondyle and you roll it down, and then once you get to the tibial plateau, it should be sitting in front of the medial femoral epicondyle. In patients with a PCL deficient knee, their tibia is going to be sitting behind the femur. So once that's complete, I'm done with my stability tests, and then I start thinking about my meniscus pathology. So the most classic exam for that is the McMurray's test. And so what we want to do is we want to get the knee, and I usually start in a little bit of flexion, and I put my finger along the joint line, and I hyperflex the knee, and then keep pressing on the joint line and start rotating the knee, internal and external rotation, to see if I can get pain along the lateral joint line, and then also I'll touch on the medial joint line. And so for the medial meniscus, I'll externally rotate the leg, and then for the lateral meniscus, I'll internally rotate the leg. But it's a combination of rotation and flexion to check for meniscus pathology. Once the meniscus test's done, some other special tests that I like to look at are the patellofemoral joint. The first test is the patellar glide test. I want to see how much the patella translates, and we try to grade it based on the width of the patella, and we divide it into 4 quadrants. And so a normal exam would be 1 to 2 translations, or 1 to 2 quadrants translated both laterally and medially. And then I would say this is a 2+ translation with a firm endpoint here, and then a 2+ translation medially with a firm endpoint. Most of the time, patients who have a patellar dislocation, they're going to be dislocating laterally. And so the next test I'll do is called a patellar apprehension test, where I put a lateral directed force on the patella, and I slightly flex their knee, and then I ask the patient if she feels anxious or apprehensive that the kneecap may be dislocating. All tests on all parts of the body should include a neurovascular exam. And for the lower extremity, there's 5 main nerves that we want to look at. First, I'll look at the motor function of the lower extremity. So I want to make sure that she can bend her foot all the way up. And that's looking at the tibialis anterior muscle. And then I want to have her bring her toe up, which is the extensor hallucis longus. And then I want to have her point her foot down, which is looking at the gastrocnemius, and then flex her toe down, which is the flexor hallucis longus. The next thing I'll look at is the sensory exam of the foot. And what I'll look at is the outside part of her foot, which will be the sural nerve, along the dorsum of her foot, which is the superficial perineal nerve. In the first web space is the deep perineal nerve. And then on the medial aspect of the foot is the saphenous nerve, and then on the plantar aspect of her foot is the tibial nerve. And then I'll feel between her first and second ray the dorsalis pedis pulse, and I'll feel her pulse with 2 fingers, and everything's normal and good. One thing that we'll see a lot in young patients that are having pain somewhere in their knee is I like to look at their kinetic chain. And a quick way for me to evaluate overall strength, balance in their lower extremity is to do a single leg squat. And so I'm going to have Avery here show us what it would look like to do a single leg squat. And here you can tell that she's actually a great athlete and she's able to do it pretty well. But something that we'll look at is sometimes the knee will collapse into valgus, and sometimes people will use their torso to kind of balance themselves. A lot of times patients with anterior knee pain, I'll find, can't initiate the single leg squat because they have weakness either in their VMO or they'll have hip weakness. And this will tell me right away, okay, therapy will help this patient, and I'll send them right away to physical therapy. and that usually does the trick.
When should we be concerned about knee pain in a child and refer them to a pediatric orthopedic surgeon?
This is a common question we get here at Scottish Rite regarding when to refer, when is this an emergency, is this something that can wait over the weekend, is this something that can wait till tomorrow morning? I think most of the time with sports-related injuries, we can typically wait to see them until the next morning. Signs and symptoms that would be concerning for possible fractures would be significant swelling, pain that's not getting better with over-the-counter anti-inflammatories, inability to bear weight for a prolonged period of time, or pain that's worsening despite all these conservative measures. If you've done a neurovascular exam, the neurovascular exam is normal, imaging, there's no fractures or things like that, then most likely it's a soft tissue injury and something that we can see the next day or within the next couple days, get an MRI, and then evaluate further based on our clinical exam and imaging.
Can you explain the common causes of patellar instability in children and how do we diagnose and manage them?
Patellar instability is a very common problem that we see here, and it really is a complex problem that we see with a lot of anatomical features. Typically when I'm talking to a patient's family regarding these problems, I like to use the knee model to help explain different features within the MRI or the x-rays that I see. And so typically the three main things that I look at are patellar height, I look at the anatomy of the trochlea, and then I also look at the tracking of the knee. And we can evaluate these on physical exam and based on the MRI. So first off is the way that the patella, the way that we're born can really dictate how the patella tracks. So some patients have a trochlea that will look like this, where they have a V in the trochlea, and the patella will come down, will start here, and then it will engage into this bony constraint. Patients that are born with a flat trochlea are more likely to dislocate because they don't have that bony constraint. Some patients have a trochlea that's shaped like this, and they're unstable every time their kneecap's coming in and out. And so the first thing I look at is the anatomy of the trochlea. The second thing that I like to look at is how high is the patella. So increased patellar height causes the patella to take a little bit longer time to get into that groove. And so patients that have increased patellar height are more likely to have their kneecap sublux because it takes longer for the patella to get into the groove. And then the third thing I like to look at, I look at the tracking of the patella. And so the patellar tendon, attaches to the tibial tubercle. Sometimes kids have a rotational problem where their tibial tubercle is attached over here, and so when they're bending and straightening their kneecap wants to track to the side. And so if we can look at their rotational profile, we can look at their patellar height, and then if we can look at the shape of their trochlea, that can give us a lot of information on how at risk they are to have persistent tracking problems.
What are the typical signs and symptoms of a meniscal tear in a pediatric patient, and how do we differentiate it from other knee conditions?
Meniscus tears are very common in the pediatric patient. A lot of times the history with a meniscus tear is a hyperflexion type injury or a twisting injury. Whenever you have a patient that has a tense, swollen knee, the top three diagnoses are either going to be an ACL tear, a meniscus tear, or a patellar dislocation, and then also a possible fracture. Meniscus, for just the anatomy, the meniscus are these structures right here, and these serve as kind of the shock absorbers of the knee. Typically, when patients hyperflex their knee, they'll have a tear, and they'll have pain specifically with bending their knee or with twisting their knee. And typically, they'll say that they have pain on either the medial or lateral joint line. Whenever I see a patient that has had that history and physical exam, typically they'll have normal x-rays, and then I'll send them for an MRI to confirm my suspicions of a meniscus tear.
What is a discoid meniscus, and what are the common signs and symptoms you see when patients present with them?
Discoid meniscus is a relatively rare pathology in the general population. We see it up to 1 to 2% of the population. However, here at Scottish Rite, we see them all the time. And a discoid meniscus is basically a meniscus that didn't develop normally. Like we see here, normally the meniscus is shaped kind of like a C right here. And so there's a couple different types of discoid meniscus. You can have a complete discoid where it's shaped more like a saucer or a plate. And then you can also have an incomplete discoid where it doesn't fully develop into the C and there's a little bit of extra tissue right here. And so typically what we'll see in the younger population under 10 is they'll have difficulty getting full range of motion, they'll have clicking or popping, and sometimes it can be in both knees. And then the younger patients will generally see a complete discoid. And the way that we treat those is we generally try to remove the extra tissue so that it'll look more like a normal meniscus. With this extra tissue in the knee, these kids are more likely to have meniscus tears. And so sometimes we'll have a story where a patient was doing something relatively benign and then they'll have pain and swelling. And if they're having pain and swelling on the outside part of their knee, I'm immediately thinking, okay, they might have a discoid meniscus. And then in our older population or in the teenagers, we'll see the incomplete discoids where they're able to kind of get through life. They may not have as many mechanical symptoms, but then they also have another injury or something, a smaller event, and then they present with pain and swelling. And then when I get into surgery, I see a little bit of extra tissue. And it's the same type of thing. We want to remove the extra tissue so they're not at risk for further tears, and then we'll repair whatever's more anatomic or normal tissue.
How do we evaluate and manage children with suspected ligament injuries, such as an ACL tear in the knee?
A lot of times patients are going to be coming, either they're right off the field or they've had a recent injury when you're seeing them in your clinic, or you'll get a phone call from them. Typically, I'll give them crutches to start out with, and then sometimes these patients will be placed in a knee immobilizer. I think most of the time I try to keep people out of knee immobilizers because we're trying to get their knees to not be stiff if they need surgery. If they're not having pain, which a lot of times kids that tear their ACL, they'll not have too much pain a couple days after the injury. I let them weight bear even without crutches. And then I try to get them moving their knee and try to get full range of motion. I think probably the biggest thing I see is a lot of kids are immobilized right away because they're having pain, and that can delay their surgery on the back end if they have a stiff knee.
How do you read a knee MRI?
When I am teaching residents or fellows how to read a knee MRI, I think it's really important to get comfortable with the anatomy and then apply your anatomy knowledge to the MRI. And first thing I do with the knee MRI is I'll bring up all three planes. And so I'll bring up the sagittal, the coronal, and the axial images. And then when I'm thinking about the knee MRI, I like to separate it kind of like 1 through 6 of, I want to look at the bones, I want to look at the cartilage, I want to look at ligaments, the meniscus, and then I want to look at the extensor mechanism, and then if there's swelling in the knee, and then also want to look at anything else. And so when I'm looking at the knee first, I'll pull up the sagittal view, and I can scroll through first. I'll usually start on the medial side of the knee, and I'll look at the bone. And here we see a normal contour of the bone, and these black triangles here are the meniscus, and then here's the tibial plateau. So as I'm scrolling through, I'm looking to see if there's any meniscus tears, and I'm also looking at the cartilage of the bone right here. And then as we go more medial into the knee, here is the PCL. And then if we go here, you can see that there's some increased signal, which would be the white areas. And on a T2 image, increased signal means that there's fluid. And whenever I see increased signal on a T2 image, that's abnormal. And so this is an example of a patient with an ACL tear. And really the ACL should look something like this, where it's a dark black line. And then when I scroll through it, you can see that there's disorganized fibers, and then the tear is right here. And the next thing that I can look at on the MRI to confirm an ACL tear is something called a pivot shift contusion. And so what I'm looking for is to see this white area on the lateral femoral condyle and this other white area on the posterior lateral tibial plateau. And what that's showing me is when the knee goes through a pivot shift, the knee is rotating. Let's see. What that's showing me is the knee is rotating off the back of the tibia. This part of the bone is hitting here, and so there'll be a bruise there, and then it'll pop back. And a lot of times when we see an ACL tear, we'll also see a lateral meniscus tear because the knee is rotating off the tibia, it's pulling back on the meniscus there, and then also we'll see an MCL tear. So there's kind of a constellation of injury. We'll usually see an ACL tear, an MCL sprain, and then a lateral meniscus tear. And so that's what that bruising pattern is when I see that bruising pattern, I know right away the ACL has been torn, because you can't have that bruising pattern with the normal ACL. And then the next thing I look at is the lateral meniscus. And see right here, see this white line? This white line is abnormal because it's a T2 image, and there's a tear in the posterior horn of the lateral meniscus, where that's a common place for the tear to be in an ACL injury. So this patient has an ACL tear with a lateral meniscus, and then the next thing I'll look at, the extensor mechanism looks to be intact. This is the patellar tendon, this is the quad tendon, the patellofemoral joint. He has a little effusion right here, and that kind of completes most of my major findings, and the sagittal image is really where you get most of your information. The next thing I'll look at is the coronal image, and this is where I'll look at the collateral ligaments, and then also I can look at the menisci as well. So I typically like to go systematically from left to right, and what I'll look at here is this is the MCL, and it comes down and attaches here on the tibia. Then I look at the medial meniscus right here, this black triangle, and I can scroll through there and look at the meniscus. And then the next thing I look at is inside the notch, where we'll see the PCL, which the PCL should be right here, and it attaches on the medial femoral condyle. And then I'll look at the ACL in the notch, and you can see here it attaches on the lateral femoral condyle in the tibial plateau right here. So there is all of that white, and that's where the ACL is torn. And then the next thing I'll look at is the lateral meniscus in here, and you can kind of see there's some signal back here in the meniscus. And then this black triangle is the lateral meniscus all the way to the front. And then the last thing I'll look at is the lateral collateral ligament, which attaches on the fibular head. And there's some signal around it, but this black line is in continuity, and so I know that the ligament's intact. And then the last thing I'll look at is the axial plane, and this really tells me if there's been a patellar dislocation or if there's any patellar maltracking. And here you can see that the patella is sitting in the trochlea of the femur. There doesn't appear to be any bone bruising here, and otherwise normal anatomy. And that's my quick way to look at a knee MRI.